Thank you very much, Ayer and Alon, for the privilege of coming back to Israel. It's always nice to be here. Yeah, very hot is correct. Although living in Florida, it's not that much different. But what I'm going to try and do in the next half hour or so is try and show you a little bit about the historical perspective of laparoscopic colorectal surgery, why it took a long time to get to where we are today. I'm not sure that a lot of the things I'm going to talk about are actually advances as opposed to different techniques and competitive techniques to achieve the same goals that we all want when we try and do minimally invasive surgery. So for many of us, at least those of us who are about my age or older, the only thing that I knew about laparoscopy before I started training in general surgery was what the gynecologist did. And we've come a long way from these, side viewing, single channel scopes to where we are today. But laparoscopy in general surgery and in colorectal surgery is not that old. If you look back at things that we use on a common basis today, open technique Hassan cannula was only devised in 1978. The first laparoscopic appendectomy, 35, 40 years ago. First laparoscopic cholecystectomy in the late 80s and early 90s. And really, from a colorectal perspective, Moises Jacobs in 1990 doing the first laparoscopic, right colectomy. And around that time is when we started getting specific instrumentation, because before that we didn't have staplers and we certainly didn't have energy devices. And most of the surgeons weren't trained at all in laparoscopy. We had no training in just standard laparoscopy, let alone advanced procedures. And what would often happen, and it may not have happened here in Israel, but people went to these courses, surgeons who had no training in laparoscopy, trained on a pig, did 2 or 3 cases on a weekend, and Monday when they came back to their hospital or their clinic, they did their first true operation, and you can only imagine what kind of bad results that bred. So there were high conversion rates, there were bile duct injuries, there were stones that were left all over the place in the United States, there were certainly lawsuits, and then some legislation which controlled to some extent what the surgeons could and couldn't do. So as a surgeon at that point, we were faced to, are we going to adopt this new technique or are we going to opt out of laparoscopic cholecystectomy? And that same question came about for colorectal surgery. And unfortunately, for many people, they did opt out of doing laparoscopic colorectal surgery for a long time. So why not adopt laparoscopic colorectal surgery at that particular point? Well, I think anybody who does this procedure now recognizes it is one of the more difficult procedures depending on which exact operation you're doing. It's often multi-quadrant. You have to control many blood vessels, which at least initially we didn't have good tools to do. We were operating on cancer a lot of the time, as one of the most common things that we do in colorectal surgery is cancer. And then unlike gallbladders or other things, you had to do an anastomosis. And there was no long-term data at that point. When we first started, we didn't have long-term data. We only had surrogate data, meaning how long was the resection that you did, what, did you get adequate number of lymph nodes, what was the conversion rate, and what was the comparison to open surgery. And for colorectal surgery, some specific things came up that really slowed down the adoption rate of laparoscopy. Complications such as port site recurrences, which thankfully we don't see now very much, but at the time when we first started this in the early 90s, people were reporting, T1 cancers, which 3 months later had wound implantations. And a lot of that was probably technique, but it also drove a lot of basic science for a while to look at mechanisms of why these things could potentially happen. People removed the wrong segments because we didn't realize how important it was to have good preoperative localization, either by India Inc. or other forms of imaging studies, and people cheated. They did operations that you wouldn't normally do, open. And as I said before, we didn't have technology at the time. We didn't have energy devices. We had, very, first generation staplers. And probably the biggest thing is the surgeons didn't have a lot of experience in laparoscopy, and they're trying to do what we would consider now a relatively advanced laparoscopic operation. And it took longer, at least initially. I would say now it's not really that much longer in most people's hands, certainly if you do enough. And there's no real financial incentive to do a longer, harder operation, at least in the United States. You don't really get paid any more significantly to do a laparoscopic operation than you do an open operation. In addition, laparoscopic colorectal surgery wasn't just one operation. It's not like a gallbladder or a hernia. It's a lot of different operations because we deal with a lot of different pathology. So there's a lot of things that people needed to learn. And again, there were multiple conditions, let alone the operations. But, you know, an ileocolic resection for Crohn's is not the same as an ileocolic resection or a right colectomy for a polyp or a cancer. But, saying that, there's a lot of potential proposed advantages to doing laparoscopic surgery for colorectal disease. And you can see, you know, this whole list of what's potential, and probably in almost any article that one looks at that looks at laparoscopy compared to open surgery, one or more of these variables is definitely going to be reported out. But if you look between 1991, when that first laparoscopic colon surgery was performed, to 2004, when the cost trial data came out in the States and the color trial and the classic trials came out in Europe, there was really a stagnation in the growth of laparoscopic colectomy. You know, there were few surgeons and few centers that really, you know, grasped onto this technology and really did it. And prior to 2004, in the U.S., only 3% of the most common disease process that you could manage laparoscopically was this done by laparoscopy. And it increased a little bit, but very slowly after the cost data came around. But probably the cost data and data like it was really the first major advance, because it took all these patients that many people excluded from doing laparoscopic surgery and now said, look, it's okay to do this. And that expanded the pool of both surgeons and patients that were available, both here and in Europe and other places. So the cost trial data basically showed that laparoscopic surgery for colon cancer was equivalent to open surgery, both in recurrence rates as well as survival rates. And what that really did is it increased what we call the adoption rate. And that's really the first major advance, is that people are actually starting to commonly do these operations. It wasn't like gallbladder surgery, where within 3 to 5 years, pretty much all gallbladder surgery was done laparoscopically. We're still at best probably 50% worldwide, and probably a little less than that in the United States at this particular time. But if you look at this particular graph, the average adoption from this paper in 2011 basically, you know, shows that we're still below 20% in many places, including Europe, both for benign and malignant disease. So we have a long way to go, and that's one of the things that we really need to push. We also have a lot of data now, finally, and the data, again, allows us to be confident that we can apply this technique safely to our patients and get good outcomes. This most recent meta-analysis looks at colon cancer. It's 12 papers looking at 4,000 patients. It looked at both short-term and long-term outcomes. These are the things that favored laparoscopy, so less ileus, less complications, less length of stay, and earlier time to resume diet, and the long-term outcomes being very similar between the two groups. And if you look at the meta-analysis, the graphs here, you can see that other than operative time, everything really favors laparoscopy over laparotomy, with the exception of the positive circumferential margin in the classic and the color trials, which is one of the big issues that came up there, and cost. Because cost is clearly, depending on how you measure cost can be more with laparoscopy than it would be with laparotomy. And again, most of the things either equivalent or reaching or favoring laparoscopy over laparotomy. Same thing for diverticular disease, and I'm not going to give you every single disease process, but the bottom line is that when they do meta-analysis and they look at laparoscopic surgery as compared to open surgery, that long list of potential benefits that we showed earlier definitely comes out in many, many papers, at least one, if not more. And the most recent database, even for something like IPAA, which was one of the first operations that we did and had dismal results with, because it was the most common operation we did at Cleveland Clinic, Florida in the early 90s. We started doing pouches that way, and we had terrible outcomes. So we stopped doing that for a while. But now I think with, again, increased expertise and things like that, you can do these operations very safely and have comparative outcomes in all the long-term outcomes with better short-term data. Rectal cancer, again, the same way. In this meta-analysis, 1,500 patients in 9 papers, lower blood loss, took a longer period of time, but again, all of the other things that one typically looks at are no different or at least improved. So, again, if you look at the literature critically, one can see that almost every paper comparing laparoscopy to laparotomy will have one or more of these advantages borne out. And I think in today's world, we should be looking for the patients who may benefit to have an open operation as opposed to laparoscopy, which is completely different than where we were 10 years ago. We were looking for patients, who was a good candidate for laparoscopy. I think that we should be in the opposite mode now. Almost every patient with specific, contraindications can have a laparoscopic operation. Other technological advances. As I said, when we first started this in the early 90s, we didn't have a lot of tools that made a difficult operation a little bit easier. So the technological advances, and I'll go through all of these, are energy devices, better stapling devices, better image quality, and other things that we use, on a daily basis. As far as advanced energy goes, this is what's, currently available. Ultrasonic, also known as harmonic scalpel, bipolar energy such as the ligature, bipolar and pressure, which is end-seal, and then there's a combination of devices that are now coming out that have one or more of these modalities available to them. Everybody uses potentially a different instrument, but without these instruments, certainly the larger operations like total abdominal colectomy or J-pouch surgery would be prohibitively difficult and time-consuming if you didn't have devices to ligate vessels quickly and confidently. So ligature's been out now 1998, so it took us 7 years to get to a bipolar energy device that we could use consistently during laparoscopy. It went from a 10 millimeter instrument now down to a 5 millimeter instrument, and it still has the largest sealing capacity for a laparoscopic instrument. You can do vessels up to 7 millimeters with either the 5 or the 10 millimeter ligature at this point. Harmonic scalpel came out a little bit earlier. Now it's available in its 3rd or 4th iteration, known as the ACE. It's a 5 millimeter shaft also, but it uses ultrasonic technology where the blade vibrates and that seals the vessels, but you can't get as large of a seal. So if you're going to use a harmonic, you have to understand that you have to, it probably does smaller vessels than some of the larger named vessels, and you either need a second energy device or you need to use a stapler potentially for larger vessels, which can add expense to it. The end-seal, on the other hand, is a bipolar energy device, which also has what's called I-beam technology. So it uses pressure to compress the vessel prior to applying the energy. And in a 5 millimeter instrument, even though it's bipolar, it can do vessels up to 7 millimeters. So comparable to the ligature, essentially. And this is sort of what the device in its current iteration looks like at the moment. I think that these are where things are going to end up going. Multiple devices housed into a single unit. So Ligature Advance has a monopolar tip, so you can do standard unipolar or monopolar dissection, and then have bipolar sealing for when you need it for vessels or for things that are slightly more bloody. Again, it's a 5 millimeter instrument. It can seal 7 millimeter blood vessels, and probably in the long run it'll reduce cost because even though this instrument may be more than a single device, it'll be less than using 2 devices or something like that. And this is the newest thing, at least in the States, which is called Thunderbeat. It's put out by Olympus. It's also a 5 millimeter instrument. It can seal 7 millimeter vessels, but it's a combination of both ultracision and bipolar. And as I said, I think we're going to see more and more of this type of a technology platform where multiple types of energy are available in a single device. And I think it reduces the number of times we have to exchange instruments, and it should reduce the cost overall. We've gotten improved stapling devices. Stapling devices initially could have been up to 15, 16 millimeters in order to get the equivalent of quote-unquote a green load, so a 3.6 staple height. Now we've gotten down, most of the instrumentation where you can put it down a 10 millimeter port. Initially, we didn't have reticulation, and we had limited reticulation, particularly for pelvic surgery. Being able to get closer and closer to 90-degree angles is now possible with some of the instrumentation that's out there. We also have a lot more choices in our staple heights and our staple configurations, which make for more secure either division of blood vessels with vascular cartridges or more secure anastomoses, again, depending on which one of those you do. And they've changed the configurations from single staple lines to double staple lines to triple staple lines, which now also should have lower leak rates, less bleeding, and better overall outcomes from the actual stapling. And they've incorporated what I call improved firing mechanisms. So one stapler company has gone to shorter multiple strokes, whereas other companies have gone to a slightly bulkier instrument, but you can do a single firing. And now I think power is going to be something that's going to be available from most of the competitors, as far as the ability to just push a button and it'll power through, giving you a much more stable suture line. Image quality is important also. If you think about the first picture I showed you of looking down a small scope and what kind of field of vision one had and how poor the optics were, to think of our TVs today with 1080 or higher high definition, that's where we're going with laparoscopy also. We have standard imaging is 640 by 480. That's the horizontal and vertical lines, compared to standard HD 1280 by 720, and where we are now at 1080 HD, which is 1900 by 1080. A much better view in the operating room. There's not a lot of studies out, but one study so far showing that just the surgeons, when they were asked, looking at the screen, do you feel that you can see better? The answer was yes. And then when they did skills, which were intracorporeal knot tying, when they compared standard definition screens to high definition screens and cameras, people could tie and do things quicker because they could see better. And I think that the standard is going to be that most places, at least in the U.S., are certainly going to all go to HD, including us, which we're in the midst right now of changing all of our operating rooms to HD. The actual scopes themselves have changed to some extent. We have flexible tip scopes which allow wider fields of vision, particularly important for pelvic surgery, and probably if anybody does single port, it can make that a lot easier. The problem is camera holders as your assistants are already potentially not the best at driving the camera, and this puts a lot more confusion in it. So you have to have someone who's a good camera holder in order to be able to use flexible tip scopes, and working with the same team can be very important. Other things that have come up throughout the years which have made our lives easier as surgeons are radially dilating or bladeless trocars, the ability to use optical trocars for re-entry into potentially a hostile abdomen where somebody's had prior surgery, creating better fields with smoke evacuators and scope warmers, a lot more instrumentation, things like pharmacologic agents, such as if you have an injury to the spleen, that you can now inject through port sites were not available previously, and port closure devices so you don't get hernias. So that's all the technical advances. But I think that the big issue is these new competitive platforms. We went from laparotomy to what we considered a very minimally invasive operation, now known as multi-port laparoscopy, right? Standard laparoscopy, to those people who have adopted single port, call that multi-port. But can we either get better outcomes, easier outcomes, by doing some of these newer technology platforms? So that the main technology platforms really are hand assist, single port, and robotics. So single port, uses multi-ports. For standard laparoscopy, you have a camera port, you have accessory ports, and you need an extraction site. Single port, everything is the same. It's your camera port is your accessory port, is your extraction site. And there are devices, as we showed here, that allow you to put multiple instrumentation through a single incision in order to accomplish that. Well, what's so bad about accessory ports? I mean, there's been reports that they can add pain. I personally don't believe that, but nonetheless, 5mm ports, we've always been told you can put in as many 5mm ports as you want. They're quote-unquote free because they're so rare to cause a problem with the patient, but the people who feel strongly about Singleport will tell you that's one of the issues. You can get port site hernias, even with a 5mm instrument. You can get bleeding. Even though these scars are little from a 5mm port, some patients may complain about those from a cosmetic standpoint. You can get organ injury as you put in secondary trocars, and maybe this additional trauma to the abdominal wall may be why, in some series, Singleport has better outcomes. But it's a brand new procedure, and as surgeons, you have to learn how to do the operation you finally learned how to do relatively well now in a different way, because the retraction's different, you don't really have assistance the way you normally do, it's different devices, your hands have to be crossed, so it's potentially difficult, and there's a new learning curve potentially if someone's going to adopt Singleport, and that may lead to all the issues that come with learning a new technology and learning curves. In addition, there's potential downsides, because depending on where you put your device, it may not be a good extraction site, for instance, for an anterior resection or a left colectomy to have an umbilical extraction. In addition, often, at least for rectal cancer, you need more than one retraction port, and that's all you have in a lot of these devices is a single extra port. So often people cheat and they put in an extra port when they do single port for certain operations. And it doesn't allow you to do any form of hybrid operation. And reoperative cases may be difficult because it's hard to put a single port back into a midline incision, for instance. And really, the only potential upsides, I think, are cosmesis and marketing. Maybe there's some improved outcomes, but I'm not really sure about that. Despite that, there are multiple publications out there at the moment which show one or more of the standard advantages that we saw between laparoscopy and laparotomy to single port surgery. Hand assist, a little bit different, I think. One of the things that we do lose with multi-port laparoscopy is the loss of tactile sensation. There's difficulty in retracting and dissecting, particularly bulky lesions, whether it's cancer, diverticulitis, or inflammatory bowel disease. And sometimes it's difficult in applying standard open surgical techniques laparoscopically, like mesenteric control, control of bleeding when it happens, which is potentially a lot easier if you have a hand in there. But hand-assisted surgery can take on a variety of different forms. One can do as little or as much as they want intracorporeally. I think that the main issue is that, it restores your tactile sensation, but more than that, it's proprioception. You know where your two hands are without even thinking about it when you have one hand inside of the abdomen. You can do blunt dissection. You can retract organs. If something bleeds, you just put your fingers on it. And depending on how you do the operation, you can get rid of a lot of other ports by having a hand port potentially in there. And it's actually not just one instrument, it's 6 instruments because it's the back of your hand and your 5 fingers. So you actually get a lot of instrumentation through one hand. I think the biggest paradigm shift for hand-assisted surgery is the fact that you make your incision first, as opposed to making it last. And therefore, you can do things through your incision throughout the procedure that you wouldn't be able to do with a laparoscopic operation. Some people would say that that's cheating, but again, the ultimate goal in all of this is improved patient outcome. So if you can get a better patient outcome, why not do some other technique if it can help you? The purest laparoscopist will tell you hand-assisted surgery is not laparoscopic. It does have a cost associated with it. It's $400 to $500, at least in the U.S., for that device, and you have to adapt the operation a little bit to be able to do it. But I think that it can, based on multiple studies, again from the literature, show that you can do shorter operative times, lower conversion rates, albeit at a slightly larger incision than you would for standard multi-port laparoscopy. But all the rest of the outcomes are very similar between hand-assisted surgery and multi-port laparoscopy. Lastly, what's the most, the most intensive thing that we have available to us is potentially the robot. Robots aren't new in surgery. In 1985, this was the first robot, the Puma 560, which was used to place a needle for stereotactic brain biopsies. This RoboDoc was an automated orthopedic procedure in 1992, and then I think most of us probably remember something called ASOP, which was something that held the camera by voice command, and you could tell the camera to move in and out with that. None of those really took off, but Zeus, which was the precursor to what we know now as Da Vinci, combined that camera with 2 operating arms, and they used that in cardiac surgery. Where we are now is with the Da Vinci. So this is either a 3 or a 4-armed robot, separate console, plus the operating arms, which are docked to the patient. This is sort of what the operating room would look like, so that the surgeon stands away or sits away from where the patient is, and then the arms get attached through laparoscopic ports into the patient. You usually have an assistant standing here that controls a suction device and any other device that one needs, and then the operating surgeon operates through this area. It scales motion so it's not one-to-one action. It has the ability to filter out tremor so that the operations look smooth. And I think the biggest issue is both the view itself, which is 3D, and the fact that you have 7 degrees of freedom and 90-degree articulation with the wrist, which may be particularly important for pelvic surgery. They say that it decreases the surgeon fatigue, and one thing that they found with laparoscopy particularly is that surgeons who have done laparoscopy for long periods of time have developed back and neck problems, and they think that this may be a way to avoid that. But really, the surgeon does the vast majority of this operation. It's a one-person operation for the most part, with an assistant doing some minor things for you. You can't feel with it. There's no haptic sensation, at least built into the current robot. The other downsides are it's very difficult to change positions of the patient. So if you need to go in multi-quadrants, often you have to do a hybrid operation where some of it is laparoscopic, and then the main component you want to do robotically, then you dock the robot. And there's no left and right tilt. It can generate a significant amount of force, which can cause tears in the intestinal wall, vessels, the mesorectum, and there's a lot of training that you need to do to get your OR up to speed, as well as the surgeons themselves. And at the current time, there's no real clear clinical benefit, at least for colorectal surgery, other than the fact that you can see better and you have these better degrees of freedom, but it's certainly more expensive. And we'll get into the cost of it in a minute. But again, these are all the things that we talked about as far as the degrees of freedom, etc. This is what your hands look like in the devices. But it's expensive, and at least at the moment, this is probably what the biggest problem is going to be. But despite the fact that it's really expensive, $2.8 million for the console, $180,000 a year for the service contract, and disposable parts that are unique to the robot of about $2,200 per case, they're selling robots like crazy, not just in the United States, but throughout the world. And this is from this year's website, off of Intuitive's website. There are 2,000 shipments worldwide throughout the world. Most are in the U.S., 350 in Europe, and 180 in the rest of the world. So despite the fact that it's very expensive at the moment, people are still buying the robot. I think for us as colorectal surgeons, maybe the pelvis is the place where we're going to have the most benefit from it. But saying that, in order to get good at using the robot, you probably can't just do it in the pelvis unless you have a practice that's the only operations you really do, and you're probably going to have to try and use it in other areas so that you get good enough and surmount that learning curve. Most people do a hybrid procedure at this point, as I said, because of the fact that you have to dock and redock the robot if you want to change positions. So that part of it is done laparoscopically and part of it is done open. If you look at the robotic colorectal literature, pretty much every kind of operation has been attempted robotically up to this point. Conversion rates are low. Morbidity rates are similar to that of standard laparoscopy. Most of the literature comes out of just a group of hospitals at this particular point in time, because it's really not fully adopted yet by the vast majority of people. It can be done for sure for almost anything that you do laparoscopically. It's safe. Is it better? Maybe, but we don't have enough literature yet. It's not cost effective at the moment, and should everyone do it? Probably not. But will everyone do it? There's a possibility. I mean, everybody wants a Ferrari, but not everybody can afford one or need one. So despite its present cost, the robot's probably here to stay. But just like with laparoscopy 20 years ago, we're still early in the experience of robotics, the literature with robotics, and probably one of the things that will come out of this regardless is that we'll get technologies that are similar to robotics for standard laparoscopy. So I think in 30 years we've come a long way in laparoscopic colorectal surgery. All the cases that should be done via an MIS approach, whether you do a robot, whether you do laparoscopy, whether you do Singleport, or whether you do hand assist, allowing the patient to get the benefit of minimally invasive surgery most of the time I think is what we should try and do. But we're getting better and better instrumentation, different platforms, and in all likelihood we're not going to see a lot of data that says that single port, multi-port, hand assist, and possibly even robotics is going to be that much different. They're going to be relatively similar, I think, because if you think about it, you're really doing the same operation by slightly different variations, but they're all a minimally invasive approach. And I don't think it really matters, because the ultimate goal is we want to improve patient outcomes, and however we can do that, we should be able to do that, but trying to do it in a cost-effective manner. Thank you very much.